Hi, so today we're going to be talking about infectious diseases in children. Infectious diseases are the leading cause of illness in children. Viral infections are much more common, but we also see bacterial infections. It's important for primary care providers to be able to distinguish serious infections from others, and preventive education and vaccinations are important to prevent infection. The pathogenesis of infectious diseases has to do with the microbiome diversity in humans decreasing. That's related to antibiotic usage and modern sanitation. It may also be implicated in some of the other chronic diseases that we see. Um, Inoculation with important bacteria occurs at birth, during vaginal birth, and the parts of the body that are essentially sterile include the brain, spinal fluid, blood, urine, lungs, and tissues. Most bacteria are harmless and are the first line of defense on our bodies against pathogens. Pathogenesis of infectious diseases includes viruses, which are submicroscopic particles. They need a living host to multiply. There's 3 criteria for virulence, and that includes inflicting serious harm, that go unrecognized by the immune system, and they spread efficiently. Viruses can also help control bacteria. Most infectious diseases in pediatrics are diagnosed by history and physical exam. So again, returning to the history that we are familiar with taking, the history of the present illness, the presenting symptoms, doing a comprehensive past medical history or an interval history if you're familiar with the patient. Include current medications, immunization status, important, family history, social history, any exposures, known exposures, complete review of systems, and diet history, as ingestion of viruses and bacteria can occur. Physical findings: a complete physical exam will be done, including vital signs. Irritability is very nonspecific in children, but it's notable. A stiff or painful neck is associated with meningitis. A new murmur may be associated with cardiac infection or fever, flow murmur. Refusal to walk can be associated with a synovitis or a septic joint. And frequent skin changes or mucous membrane changes are associated with particular viruses or bacterial infections. In addition to history and physical, we sometimes utilize lab or imaging studies, and those include blood tests that could be complete blood counts, cytokines, pro-inflammatory reactants. It's important to note that the quality of the specimen affects the reliability of results. Also, the timing of the collection. We need to make sure that we know what the volume or quantity is needed for a particular test, and also what type of tube or container the sample should be transported to the lab in. The CBC is frequently a first-line diagnostic aid when we're evaluating a patient for infection. And with the white blood cell count, a high white count is often associated with a bacterial infection, whereas viruses can sometimes suppress the bone marrow, and we can see leukopenia associated with a virus. The differential of the white blood cell count further focuses the diagnosis. In terms of the platelet count, we sometimes see thrombocytosis in acute infection. C-reactive protein is a nonspecific marker of inflammation. It's often more elevated in the acute phase. Procalcitonin is a newer biomarker that is sometimes used in more ill patients when you need further information and trying to differentiate what is the cause of the child's illness, not frequently obtained in primary care setting. The SED rate we do often check in patients who are febrile or not feeling well. When we decide that we want to obtain a CBC, we will also obtain an erythrocyte sedimentation rate. It's also known as the ESR or the SED rate. It gives us an indication of some type of inflammatory process going on. It's another nonspecific test, but we are reassured if it's low, and we worry a little more if it's high. We will often obtain cultures or some other type of testing related to organisms and their susceptibility to medications. As always, we want to educate our families on how to prevent the spread of infection through frequent hand washing, using alcohol-based rubs, and that we need to be watchful and good stewards of antibiotic use. We don't want to be pressured into treating our patients with antibiotics when they're not needed. There's a fair amount of literature out there on how clinicians who understand the responsibility around antibiotic stewardship and yet continue to prescribe antibiotics when they are not necessary for a number of reasons, not the least of which is to please the parents. So we definitely want to be aware of this pressure that may fall upon you when you're out in practice with patients who become angry or dissatisfied when the child doesn't receive treatment, and we need to make sure that we continue to self-evaluate ourselves, that we are following clinical guidelines and also doing our best to educate our families on the risks of inappropriate antibiotic usage. Pathogens and modes of transmission in childcare settings. I just put this table in here. This is directly from the Burns textbook, chapter 24. Because so many of our patients are in childcare settings, it's important to be aware of some of the common infectious organisms that do go around these centers and why we do see more illnesses in children who are in daycare settings. So again, when we're doing our history, we do always ask if there's known exposures. Often, once one child in a daycare center becomes infected with one of these organisms, it will pass through the entire center, and it will be important for us to know that information when we're evaluating a child who's presenting with an illness. Just going to review briefly some specific viral diseases that we haven't covered already in other modules. The enteroviruses are a common cause of febrile illness in children. There are many different serotypes. They can cause numerous types of illnesses, including aseptic meningitis, hand, foot, and mouth, herpes. They primarily invade through the GI tract, but they are transmitted via the respiratory route. They can be transmitted transplacentally, and infants have the highest prevalence rate. There are several subtypes of enteroviruses. The common history is, mild URI symptoms, nonspecific febrile illness, and on physical exam, there's often a rash. The rashes can vary from macular to MAC-PAP, urticarial, petechial. Herpes angina is associated with lesions on the oropharynx. There can be acute lymphonodular pharyngitis, and meningitis presents often with a fever and a stiff neck and headache. Certainly, we'll talk a little bit more about meningitis in the next few slides, but you can't tell by looking at the patient whether the meningitis is bacterial or viral, and since meningitis is such a fast progressing, potentially fatal illness, when it's bacterial, we need to make sure that we evaluate any patient carefully who presents with fever, headache, and stiff neck, or even just fever, headache, and vomiting, which is a classic triad for a presentation for meningitis. The hepatoviruses, again, Hep A, Hep B, Hep C. Hep A virus causes a primary infection in the liver. Hep A is generally transmitted by the fecal oral route. Poor hand washing after using the bathroom. think fast food joint. You occasionally hear on the news that there's an outbreak of Hep A at the local, um, I don't know, Burger King, Taco Bell. So, however, most kids are not symptomatic. So even if they contract Hep A, we may not even know they've had it. Only 30% are symptomatic, which is part of the reason why it can spread rapidly. It's usually self-limiting. If there's a known exposure, immune globulin can be given to help prevent infection. However, hepatitis A now is given. I put question marks there because it's recommended to be given as routine, but I'm not sure that it is given routinely in all centers because it used to be given at the 1 year visit, and I don't think it's given anymore. I'm not sure. So I looked at several sources that say it's recommended, but I'm not sure the schools are requiring it. So I'd be interested to hear from you what you're seeing in your clinical practices. Hep B virus, we know, is a virus that, causes liver infection. It's transmitted through blood and body fluids. Perinatal transmission can occur. So for our perspective, we need to be aware of what the hepatitis B status is of the mother when we're evaluating our newborns. If the mother was hepatitis B positive, that we need to make sure the baby received the hepatitis B immune globulin as well as the hepatitis vaccine within the first 12 hours of life. And to make sure, check the newborn records to see that that was done. Other things we need to be aware of: some families are refusing the hepatitis B vaccine, and since this is a infection that's transmitted through blood and body fluids, children will sometimes share toothbrushes during sleepovers or things like that. So just be aware that if your patient has not been immunized against Hep B, that you are aware of what some of the clinical signs are, including fever, nausea, mild hepatomegaly, and icteric presentation would be later sign. Hep C, just mentioned briefly that for our purposes, we most often come into contact with evaluating a patient for hepatitis C if the mother is Hep C positive and we're seeing a newborn born to a Hep C positive mother. Perinatal transmission is the major route for infecting children. Approximately 6 out of every 100 infants born to an HCV-infected mother will become infected. Mothers who are hepatitis C positive and HIV positive have a 2 to 3-fold increased likelihood of transmitting the virus to their infants. However, vaginal birth and breastfeeding do not contribute to higher rates of transmission. So women with Hep C virus alone and not HIV positive should not be discouraged from vaginal birth or from breastfeeding. So again, we do not need to discourage hepatitis C positive mothers from breastfeeding unless they are also HIV positive. And in terms of testing the newborn, because newborns can have the anti-HCV antibody passes through the placenta from the mother, so and it can remain in the newborn's circulation for up to 18 months. So we don't test the baby until at least 18 months. Moving on to herpes family of viruses. Commonly, we are familiar with HSV1 and 2. HSV1 causing primary oral labial lesions, HSV2 causing primary genital lesions, but both types are associated with both areas of infections, and both types can be devastating to newborns. Type 1 is the most common in children for gingival stomatitis, and type 2 is usually the result of sexual activity. Neonatal HSV2 can be acquired from the mother during delivery through the conjunctivae, the nose, mouth, or any broken skin areas, such as from a indwelling monitoring probe, internal monitoring. So for an infant that was perhaps fetus that was needed internal monitoring due to poor tracings, that can be a location where the virus can transmit. It can also be postnatally. The communicability is 2 days to 2 weeks, and some congenital infections can take up to 6 weeks to manifest. Diagnostic studies, cultures are done within 12 to 24 hours after delivery. HSV is always suspected in neonatal sepsis and needs to be suspected due to its devastating effects if untreated. And so if neonate's cultures for HSV are positive, they will be treated with parenteral acyclovir, and they will go home on oral acyclovir for 6 months after they finish their parenteral treatment. Moving on to other types of viruses in the herpes family, including infectious mononucleosis syndrome. This is a viral infection commonly seen in teenagers, although we do see it in younger children. I have seen it in toddlers. There is a classic set of presenting signs associated with mono, including extreme fatigue and excessive sleeping, body aches, fever, swollen tonsils, sometimes extremely swollen tonsils with sore throat, swollen cervical lymph nodes, especially posterior cervical lymphadenopathy, so you should assess carefully for that. The liver is often swollen as well as the spleen, so you always want to do an abdominal exam and palpate for hepatosplenomegaly. On a CBC, you will see increase in atypical lymphs, and if you feel a large liver, you can obtain liver function tests, which are often elevated. You would obtain a monospot, and just be aware that the monospot is usually falsely negative unless the symptoms have been present for at least 5 to 7 days. So if your patient has signs of mono, you want to know how long they've been feeling ill. You don't want to do the monospot too early because it'll be falsely negative. You want to wait until about a week of illness. You consider other causes of hepatosplenomegaly in your differential, as well as other causes of swollen tonsils, which can include group A, beta, strep throat, which you can have simultaneously with mononucleosis syndrome. And the management of mono is basically supportive with bed rest, over-the-counter analgesics, although there are rarely cases where the tonsils are so swollen that steroids need to be given. Usually that is done in consultation with the pediatrician or ear, nose, and throat specialist, and occasionally children will be admitted to the hospital to receive their steroids IV due to the risk of airway what's the word I'm looking for? Compromise. In addition, it can take 1 to 2 months for the liver and spleen swelling to resolve, so we usually recommend that adolescents avoid contact sports for at least 1 to 2 months after their infection has been diagnosed to ensure that they are safe and will not, risk having a splenic rupture. Continuing on with other types of herpes viruses that we see in children, including Roseola infantum, which we talked about already. This is common in infants, usually about 6 to 24 months of age. It's a very classic presentation where they'll have a sudden onset of fever for usually it's 3 to 4 days without seeming particularly ill. And as the fever resolves and effervesces, a rose-colored macular papular rash appears. And this is self-limiting, and usually the child feels much better when the rash appears. Varicella is in the herpes family of viruses, the primary cause of chickenpox. We don't see it that much anymore because of vaccine. However, because parents do choose not to vaccinate, we do occasionally see a case of the chickenpox. Shingles is reactivation of latent varicella virus. This virus is transmitted by direct contact droplet airborne transmission. And victims of shingles infection can cause primary varicella illness. Incubation period is 10 to 21 days, but the communicability is highest 1 to 2 days before the rash erupts, which is often when people don't even know that they are infected, and which is why it can spread. There are complications associated with chickenpox, which is part of the reason that led to the development of a vaccine. Pyoderma, or what was known as flesh-eating bacteria, had been seen in children with chickenpox infection, as well as pneumonia, pneumonitis, encephalitis, and other infections. More systemic infections can occur with chickenpox. If a child has been exposed and is at risk for getting the chickenpox, hasn't been vaccinated, then they should wait for 1 week after they've been exposed. Unless they develop signs of illness, then they can return. Moving on to influenza, since we are coming upon the flu season. Influenza is a viral infection that tends to present with a sudden onset of high fever, headache, chills, coryza, vertigo, sore throat, myalgia, and dry cough. It's a fairly classic presentation and fairly sudden onset for a viral infection. Usually viral infections have more of an insidious onset, whereas bacterial infections have more of a sudden onset, but the flu tends to present in this way. In younger children, they may also have nausea, vomiting, and croup-like symptoms. Infants will appear septic. There can be conjunctival infection, nose bleeding, and even myocarditis. Lower respiratory tract involvement can occur in severe infection. There are rapid diagnostic tests which have limited sensitivity, so we believe them if they're positive, but we don't necessarily believe them if they're negative. So if you do a rapid flu test on your patient and it's negative, you cannot rule out the flu. You would have to do a viral culture. And this wasn't in your textbook slides, but we do treat children younger than 2 who are symptomatic, and we can talk about that in class. I can look up the dose of the medication that we use, especially in light of flu season coming upon us. So we can remind me to discuss that in class, or look that up yourselves and we can talk about it in class. Briefly mention HIV infection, especially in terms of its transmission through breast milk. So I think currently we still do not recommend breastfeeding in HIV positive mothers in this country. And that's because the risks outweigh the benefits, given the healthcare that we receive, and the good vaccine program and medical care and everything that we receive. However, in developing countries, they do not restrict breastfeeding. This is, again, unless anyone has more recent information than I do, the most recent information that I'm aware of is that in developing countries, women are still encouraged to breastfeed because the benefits are so do outweigh the risks in developing countries, whereas in our country that is not the case. So, and the treatment of pregnant women who are HIV positive is virtually eradicated perinatal transmission of HIV. So, it's good news. Measles, again, a vaccine preventable infection. However, as you know, if you watch the news, because of the folks who are choosing not to vaccinate their children, we are starting to see resurgence of this infection. It's a serious infection. I have seen a measles outbreak when I was a new nurse. Some very, very sick babies and children in the hospital who had measles, and it causes a significant viremia. It appears in respiratory secretions, blood, and urine, and it's highly contagious, so 90% of susceptible individuals will develop the disease when exposed. The incubation period is 8 to 12 days. But again, like most viruses, the most contagious period is 1 to 2 days before the onset of the symptoms to 4 days after the appearance of the rash. There's a prodromal period of URI symptoms, low to moderate fever, and then what we notice, the 3 C's, cough, coryza, and conjunctivitis. And then the classic diagnostic finding is the Koplik spots, which are bluish-white granules on an erythematous base on the buccal mucosa. And I remember vividly during this measles outbreak that we had at Boston City when I was a new nurse there, all the residents and medical students coming in and looking specifically in our patients to see these Koplik spots. So that's sort of the classic finding. Then there's the rash stage on the third or fourth day with development of a maculopapular rash behind the ears, the forehead. Then the papules enlarge, they coalesce and progress downward. They have high fever, they have respiratory symptoms, really irritable, really sick. They don't want to eat. They're at risk for dehydration. The rash can become hemorrhagic and even lead to disseminated intravascular coagulation. Measles is reportable. It can be diagnosed through IgM levels or viral isolation. Management is supportive. Immunocompromised children should be referred to infectious disease. I'm not familiar with vitamin A therapy. That must be relatively new treatment, something that if you have time to look up and we can talk about in class. And exposed individuals should receive immune globulin to help modify the disease. Complications include bacterial superinfections, myocarditis, puerperal fulminans, and encephalitis. So again, this is why we really want to help educate our families on vaccinating their child against the measles, reassuring them that there's no evidence that the MMR causes autism, and that's not a good reason to decline the MMR vaccine. It's really a profound infection. Moving on to the mumps. Again, another vaccine preventable infection, and one which is prevented through the MMR vaccine. Mumps is acute viral disease, it usually manifests as painful enlargement of the salivary, generally the parotid glands. And the child appears to have a sort of a chipmunk appearance, and the parotid gland swelling obscures the mandibular angle. So that's how you can differentiate it from lymph swelling. It's usually a preauricular swelling that obscures the mandibular angle. And this also has a prodromal stage, a rare fever, headache, anorexia, neck pain, malaise, and then the swelling, which can be unilateral or bilateral, and can also manifest as orchitis, which is swelling of the testes in pubertal males. Once a child has been infected, and that can actually lead to sterility. Once a child has been infected with mumps, they have lifelong immunity. And again, it's supportive care, and you would diagnose it with a mumps antibody test. And parainfluenza is another common virus that we see that can cause these types of illnesses. We don't necessarily know, that it is causing that because we don't test for it, but routinely. But in cases of bronchiolitis, bronchitis, croup, pneumonia, any of those infections can be a result of the parainfluenza virus, or commonly called paraflu. And you can test for it like you can for RSV, but it isn't frequently done unless you had a really sick patient and you really need to know what was going on. But just so you know that there are other viruses out there that cause these types of illnesses. Moving on to mosquito-borne viruses. We're sort of getting out of mosquito season ourselves now, but it's important for us to think about these types of mosquito-borne viruses in the months when our patients are out there and exposed to mosquitoes. So West Nile virus is one. It is transmitted by a mosquito. It's rare to be transmitted from human to human, and symptoms occur usually 2 to 14 days after a bite. It mimics an influenza-type illness or a GI infection. In mild cases, the symptoms will resolve in a week. In severe cases, there can be neuro involvement. An enzyme-linked immunosorbent assay, ELISA test, can make the diagnosis. And in mild cases, it's just supportive treatment. With severe cases, it's hospitalization, and people can die from West Nile virus. Tick-borne diseases, just going to cover briefly Lyme disease. Again, we're getting out of Lyme season, although with our warmer weather this fall, I'm not sure if there's still some ticks around out there or what stage they are in. They do evolve. They have a life cycle, and I'm not sure what stage they tend to be in at this time of year, but we are in the Northeast, so we have a high incidence and prevalence of Lyme disease. And the clinical findings, there can be mild flu-like symptoms, fever, a low-grade fever. What makes life easy for us is when children present with the typical rash, the erythema migrans rash, or the red bullseye rash. It says here it may resemble nummular eczema, but the reality is it's a very flat. It's almost like a discoloration of the skin in a circular pattern. So it's not really a palpable rash. It's really a macular, flat, round, red, pink, dark pink rash. And so that's the early stage, and it's considered early localized stage. And if treatment is begun at that stage, it's very easy to clear the infection. You do not need to do lab tests. The classic erythema migrans rash is diagnostic, and so no serologic testing is necessary if the rash is present. If you have a rash and it's the first time you've seen it, you would probably want to get a second opinion to make sure that that's what it is. But once you've seen the Lyme rash, you know it. Moving on to the second stage of the early disseminated disease, you can see multiple bullseye rashes, multiple pink, circular, ring-like lesions. And I've seen children come in and it really looks like someone dipped a glass into pink food coloring and just pressed it all over their body. They had all these like round, flat, pink circles all over them, multiple. And, you walk in the room and it's like in 10 seconds, you know what the child has. It's Lyme disease. So I've seen it I saw the youngest kid I saw was a 9-month-old baby covered in pink circles. And then I've seen another child with the same. So they can also develop neurologic signs. Lyme disease can cause meningitis. It can cause Bell's palsy. So you want to do a neurological exam on your patients. It can also cause cardiac involvement. So you want to listen closely to the heart for the rate and the rhythm and the heart sounds and make sure they're normal. And so these generalized manifestations can last from 2 weeks to years. And again, you want to treat for, I think it's 3 weeks we treat for with doxycycline for kids over 8 and amoxicillin for kids under 8. You probably went over that in pharmacology. And then late disease in undiagnosed and untreated Lyme can last for weeks to months to even years. I guess there are people out there with chronic Lyme. But I think the most important thing to remember is to always have a high suspicion for Lyme disease. It can also present with joint inflammation as well, and I've seen children present with that as their only sign. They never had the EM rash, or it was never noticed, and they develop a painful, swollen knee joint or other joint. And so you would do the Lyme testing in that case because it isn't the classic, EM rash. So just, try to remember to always have a high suspicion for Lyme, especially if you stay working in this region of the country and, whenever there's ticks potentially around. Also, we see a lot of the kids who go down the Cape. It's common for them to say they just came back from a week on the Cape. That is often a red flag as well. The testing, so if there's no EM rash and you have to go forward with serologic testing, it is a 2-step approach because there's a lot of high false positives on serologic testing. So you would move forward with the Western blot. And like I said, that's the treatment. Early, late disseminated, or any concerns about neurological involvement, you would consult. And we mentioned briefly the post-Lyme syndrome, which I haven't really seen any cases of. But the most important thing is to make sure we're educating our families on using insect repellent and making sure you're checking the guidelines on the safe amount of DEET for use in children. You really need to have DEET in the repellent to keep the ticks away. I think we used to say less than 10% DEET or less than 20% DEET, but you can look that up yourselves and see what the current guidelines are. Most important thing when parents call and say that they found a tick on their child is to tell them to remove it safely, getting the whole tick out. So grabbing it towards the head, which is the part that's embedded, and pulling straight out. They do have tick removers. I have one that I use on my dog where you just sort of scoop under and twist it. And I usually tell parents to get one of those. And you sort of hook under the tick and then you spin it, and they like release when it spins, and they come out easier. And then to just tell the parents to watch for any signs of illness. I do not believe that there's an indication for prophylaxing children at this time. There is one for 18 years and older for tick bite, but I do not believe we are prophylaxing children under 18 at this time. I'm just going to mention Rocky Mountain spotted fever, because apparently it is found in all contiguous states, which I did not know, except Maine and Vermont. And it was a question on one of my recertification exams that I have to do every few years to keep my certification up. So I figured I would mention it. It's in your textbook. It's also a tick-transmitted infection. Again, it has sort of a general presentation: flu-like illness, fever, chills, myalgia, and rash. Apparently the rash is diagnostic, but I've never seen it, so I would probably test myself if a patient presented with a weird, these clinical findings and a rash that I couldn't diagnose. And I guess we have to remember to keep this in our differential as well. It's also treated with antibiotics, and also can have neurologic deficits. So again, I have not seen this. I'm not sure what the prevalence of this is in our area of the world, but something to keep in mind. And then we're going to end, I think we're ending with a few bacterial infections that I do not think we've covered yet, not including the ones that we've covered in other modules, but I know we talked about MRSA a little bit, so I just have one slide to remind us to stay aware of what the prevalence is in the area in which we practice. That MRSA can cause pneumonia, as well as deep tissue infections and other system infections. Clinical clues to MRSA being the offending agent is boils. We talked about this already. So furuncles or boils are often associated with MRSA. If the infection fails treatment with a beta-lactam antibiotic, we have to think that it could be MRSA. If other family members have similar infections, skin or soft tissue infections in neonates, history of recurrent small, non-tender maculopapular lesions or multiple lesions, ethnic minority or lower socioeconomic status, history of hospitalization in the past year, attending daycare, and being less than 2 years old. So just keep that in mind when you're evaluating patients with signs of bacterial infection as clinical clues to MRSA. And then I will mention briefly cat scratch disease, because I have seen this. You may see it. You should be aware of it. It's a common cause of chronic persistent lymphadenopathy in children. Most are caused from cat scratches, usually kittens. The clinical findings are small erythematous papules which heal, and then this lymphadenopathy in 1 to 4 weeks, which can persist for a long time. It can lead to a Paranod oculograndular syndrome, which is painful non-suppurative conjunctivitis, preauricular lymphadenopathy. In immunocompromised patients, it can cause more severe symptoms. There is a diagnostic test for this, and most cases will resolve on their own. But if there was a concern for systemic spread of infection, you would treat with antibiotics. So just be aware that this can be the cause for persistent lymphadenopathy. And then we're going to talk briefly about meningococcal disease, again, because this is an infection that is life-threatening. There are many organisms that can cause meningococcal disease, but Neisseria meningitidis is the most common one and the very deadly one. It appears in respiratory tract secretions. We often see epidemics in semi-closed communities such as daycare, dormitories, residential homes. Clinical findings for occult bacteremia can be a febrile URI, a GI infection. But with meningococcemia, there is a rapid progression over just hours, from fever to septic shock to petechiae to purpura fulminans, hypotension, DIC, and death can occur within hours. And early signs of meningococcal meningitis include fever, headache, and stiff neck, and also fever, headache, and vomiting. Even if you don't have a stiff neck, if you have a patient that complains of those 3 things, you should definitely be examining them closely, including neurologic tests and performing the meningism testing, which I have a picture of here, which are known as the Koenig's test or the Brudzinski's test, and I do both of these on patients who present with that classic triad. If you have not practiced these tests, we can go down to the lab and practice those. You can read through how to perform the test, but they look for meningeal signs in the neck. So diagnostic studies, you'll be getting blood tests on these patients, gram stains, CSF. Certainly if you're worried about meningitis, you're going to be sending these children to the emergency room. Viral meningitis can be in the differential. Again, it can present similarly, although the bacterial meningitis does progress rapidly and the viral meningitis does not. Usually they would not present as ill, but you need to keep your suspicion high in the beginning until until the results of some of the tests are back. Let's see. So again, hospitalization is mandatory, IV antibiotics, and if there is a positive case of Neisseria or other bacterial infection leading to meningococcal disease, any close contacts, household contacts, dormitory contacts, classmates, daycare contacts will need chemoprophylaxis as soon as the index case has been identified. And so often it's rifampin. The state Department of Public Health needs to be notified, and they track down all contacts for treatment, and then you would probably be getting a call from your patients letting you know that they've had an exposure and that you would need to order chemoprophylaxis. Moving on to TB, you're probably familiar with TB at this point in your education, but it's good to quickly discuss it in this infectious disease module, just because we do still see TB around. It's definitely not eradicated, and so we need to be considering the risk factors and screening patients and testing patients who screen positively. The highest conversion to disease is in infants, young adults, and then older adults. So it looks like, children between infancy and teen years are less likely, and also middle-aged people, which I don't understand, but that's an interesting statistic. So primary pulmonary TB presents with low-grade fever, non-productive cough, decreased appetite, weight loss, and night sweats. 25 to 30% will have extrapulmonary symptoms. And I actually we had a case when I was working at the health center of a child that had a lymph node, a fixed lymph node that ended up being a manifestation of TB. So it is spread by droplet from coughing, sneezing, or talking. We see it in immigrants or those that have traveled recently to TB prevalent areas. Risk factors include having clinical signs of TB, being HIV positive, being exposed to HIV, or being a drug user, living in homeless shelters, being in a correctional institution or nursing home. And we do see some teenagers who live in halfway houses or other types of correctional facilities. So we need to make sure that we are assessing the social history of our patients and any risk factors that they have for TB. In terms of diagnostic, there's 3 levels of positivity on the TB skin test. Only 5 millimeters of induration is necessary to be positive in those with a close contact of TB. 10 millimeters or greater is considered positive if you're under 4 years old with any high risk factors. And 15 millimeters or greater is considered positive if you're 4 years of age or older without risk factors. And the induration occurs after 72 hours. Let's see. Almost done. So if you have a patient with a positive PPD, you will obtain a chest x-ray, and you should consult with your local health department on the latest antitubercular treatment, because it does change. Generally, it's isoniazid that is given, and there's dosing, weight-based dosing for children. Usually the treatment is for 9 months. Usually children, it's just a single medication. But you definitely want to consult with your local health department on the latest treatment guidelines. And be familiar with the screening tests for which children should be tested, which should have a PPD test done. We used to do it much more routinely than we do now, so you would screen children first using these guidelines here, and then based on the results of the screening test would determine whether a child would need to have a PPD planted. I guess most commonly what I see now is older kids who come in because they've applied for a job either at a health facility or someplace like that, or they're going into a nursing program or something at college and they need to have a PPD. So we do see a lot of kids coming in for PPDs, and we read a lot of PPDs, and we occasionally see a positive. So it's definitely something you're going to see. So that's the end of this presentation. I hope that this was helpful. And as always, we can discuss any questions or concerns in class. That's the end.